I think we should get started just to make sure our speaker has enough time. Thank you very much for coming. Welcome again to Internal Medicine Grand Rounds. We're once again honored to have one of our own here today, Dr. O'Hare, who started her training in Cambridge University, the British Cambridge, before coming to the University of Virginia for her medical degree. She then did her internship and residency at Stanford before starting renal fellowship at UCSF, and then she came here and is now an associate professor in the Division of Nephrology and is a staff physician and core investigator at the Seattle Veterans Hospital. She's a member of the editorial board for several nephrology journals and serves on multiple national committees and task forces, including the steering committee for the Renal Coalition for End-of-Life Care and chairing the Geriatric Nephrology Advisory Group. She's the co-PI on the Renal Data Systems Special Study on Palliative and End-of-Life Care, and serves as the PI for several other large ongoing chronic kidney disease studies. She's published diversely on a number of topics in nephrology, but lately seems to have focused on clinical outcomes in CKD and ESRD patients. She's spoken nationally and internationally on these topics, and we're lucky to have her here today to talk about caring for patients with kidney disease, shifting the paradigm from evidence-based medicine to patient-centered care. Thank you very much, Dr. O'Hare.
Thank you very much. Appreciate the introduction. Today, I chose this topic, and I'm going to illustrate it using examples from my own field, nephrology, caring for patients with kidney disease. But my hope is that this also has some relevance to other fields. I don't think it's what I have to say is relevant only to patients with kidney disease. I think it has broader significance. So I wanted to take some time at the start to talk with you about the history of evidence-based medicine, which many of you will be familiar with. This is a 1992 paper that came out in JAMA from the Evidence-Based Medicine Working Group. And what they described was a new approach to teaching residents in medicine that had been developed at McMaster University in Canada. And essentially, this was really presented and essentially was a paradigm shift in certainly medical teaching, where the previous sort of expert-based approach to medicine, where you learn from your residents ahead of you and your attending, this presented an alternative approach where you learn to search the literature, to look at data from populations to inform the care of individual patients. And this has become so fundamental, I think, to how we practice now that we forget that it wasn't always the accepted paradigm. And so this was a way of getting away from the sort of N of one approach to medicine and sort of expert-based approach. And actually, this is a personal interest to me. I started medical school in the early 90s and residency in the late 90s. And this is from a letter to the I believe, to the Lancet, looking at sort of the rise in references to evidence-based medicine in the literature. And this title, I love the titles in the Lancet letters to the editor. It was called The Rise and Rise of Evidence-Based Medicine. And as you can see, this is sort of there was really a marked increase in the mid-90s onward, referencing evidence-based medicine in the title or content of abstracts. And some key figures in evidence-based medicine. Gordon Guyatt actually sort of introduced the term evidence-based medicine. And sort of these figures really sort of drove the field. Alvin Feinstein so there were several developments that were very sort of synergistic with the development of evidence-based medicine. And this was sort of the development of clinical epidemiology. So Alvin Feinstein is often known as the father of evidence-based medicine. And essentially, this was sort of the science behind evidence-based medicine. And sort of the population-based versus focus on individual health, the focus on measures of incidence, prevalence, relative and absolute risk, and a focus on the randomized controlled trial as the fundamental aspect, fundamental methodology essential to evidence-based medicine, and also on meta-analysis, the science of comparing across populations, comparing across studies, were really new developments. There was also sort of an educational infrastructure that developed around evidence-based medicine. So the first master's program at McMaster was established in 1970. In the mid-'70s, the Robert Wood Johnson Clinical Scholars Program was established. And then the first textbook of evidence-based medicine in 1982, and there have been many since that time. And then sort of a journal infrastructure that provided a natural home for work in this field. So, for example, JAMA established the Rational Clinical Exam and the User's Guide to the Medical Literature. The Annals of Internal Medicine established the ACP Journal Club. And then the British Medical Journal, more so actually than the Lancet, was a natural home for pieces in evidence-based medicine. And a lot of this had to do with who the editors were, who had influence. And then the article I showed you at the start, the 1992 McMaster Manifesto, as it's often affectionately and sometimes not so affectionately called, appeared in JAMA. And then in the early 90s, the Cochrane collaboration, which has become a huge force, I think, in providing supporting infrastructure for evidence-based medicine, was established in the early 90s. And as I mentioned, the randomized controlled clinical trial is valued in an evidence-based medicine approach above other forms of study design. And I think we should remind ourselves that, until recent years, the randomized controlled trial was not a very common form of investigation. But, in the mid-1700s, the very first trial, unless you want to go back to biblical times, but I think, in the mid-1700s onward, the first trial was actually a study by James J. Lint of citrus fruit for treatment of scurvy on passengers on a ship. And some of the controls weren't too palatable. One of the control arms was actually giving salt water as a treatment. So needless to say, the people who got citrus fruits actually recovered well enough to take care of the other patients who were not so fortunate to get citrus fruit. So this is, obviously clinicaltrials.gov was not established until 2000, but you can see that the number of clinical trials has really increased markedly since the establishment. And really, back in the 60s, even 70s, 80s, the clinical trial was not a common study design. And one of the things I think is important to recognize is that there were, in addition to the establishment of clinical epidemiology as a field, there were a number of other parallel developments that have really benefited from the sort of paradigm or framework of evidence-based medicine, and in some ways have fueled the rise of evidence-based medicine. So they've both benefited from the structure, but have also, in a sense, promoted the, I would say, primacy of evidence-based medicine in research and practice. So, you can think of, for example, the FDA drug approval process, which has developed over a similar time period, is really based around results from clinical trials. And of course, clinical trial evidence is required for the approval of drugs by the FDA. There are a number of books, and I would actually recommend all of these if you haven't read them. There are a number of books that came out in the mid-2000s around the time that Medicare Part D was coming out. And many were drawing attention to the role of the drug companies in shaping clinical practice in particular. And in particular, I'd like to just focus for a moment on this book by John Abramson. John was a former Robert Wood Johnson fellow and was practicing somewhere north of Boston for several decades in a sort of thoughtful way, reading the medical literature, taking care of his patients, and kind of became upset in a way at reading some of the articles he was seeing in some of our more prominent journals, and felt that many of them didn't really apply to the patients he was caring for. And worse still, he felt that some of them were actually misleading, especially if you just read the title or the abstract and didn't, as was his tendency, to delve into the real substance of the methods. And when I was reading his book, it actually sort of had an epiphany of my own a little bit. He did a lot of, he wrote a lot about cholesterol trials and cholesterol guidelines, and actually this book had, I think, a big impact in terms of reining in the guideline process for cholesterol treatment or lipid management. But he made the point that many drug trials compare a particular drug intervention to a placebo. And his question was, well, why don't they ever compare it, for example, to diet or exercise or other things that, might be used to lower cholesterol and reduce cardiovascular risk? And, when I read that, I kind of thought, well, of course they're not going to, compare, a drug to it. And in a way, it seems sort of like a ridiculous request. But the more I thought about it, I thought, well, no, actually, that's true. I mean, that kind of information would be helpful as a patient and as a provider to know, because it would help the patient to decide among the many potential interventions that they could pursue to reduce cardiovascular risk, which would be good to put their money on. And so it's a simple point. It's easy to miss if you're sort of steeped, as we all are, in the current culture of evidence-based medicine. But I think important to recognize that when you see a drug trial described in the literature, reported in the literature, that somebody made a decision about what to study, not to mention how to study it. So, and I think one of the most powerful illustrations of the power of publishing your results in a high-impact journal comes from this clever paper that looked at the impact of the ROUSE trial, which was a trial in the late 90s that compared spironolactone to placebo for patients with heart failure and found a lower risk of heart failure in the intervention arm. So the results of this trial were rapidly adopted into practice. And this was a study also appearing in the New England Journal of Medicine. The first study was also published there. That looked at the use of spironolactone in a Canadian registry after the publication of the ROUSE trial. And as you can see here, the rate of spironolactone prescription went up dramatically, much more than the black line is what you would expect. So unfortunately did the rate of hyperkalemia in the same community, mainly because the results of the trial were actually applied to a population that was very different from the study population. It's an older population with a higher prevalence of diabetes and kidney disease, actually. And so this was sort of a high-impact publication in and of itself. But when you read the discussion, the authors make this point that this first graph I showed you really shows the impact of randomized controlled trials published in high-impact journals can really impact practice. And if they're trials that are funded by a drug company, this can be a good way of selling your drug. And that is maybe a little different, the kind of usual stuff that I think we are wiser to. The other place, of course, where we see the impact of evidence-based medicine is in the clinical practice guideline process. And the explosion that we've seen in clinical practice guidelines over the last several decades really could not have happened without the framework of evidence-based medicine and the faith that we have in it. So as you know, a clinical practice guideline is really ranked very explicitly in terms of the level of evidence, and there's a very clear evidence hierarchy, which is that evidence from randomized controlled clinical trials are needed to support the highest level of evidence. And again, there are some books that have, and this is by no means all of them, but some books that have come out that have been somewhat critical of the guideline process and the impact that this can have on practices. And as you know, many times drug companies are involved in at least sponsoring guidelines, and many times, I think we've become somewhat wise to this, but many times the experts on the guideline panels have conflicts of interest, are receiving payment from drug companies, et cetera. And there's all sorts of other I think, sources of conflict of interest in the guideline process. But in selling sickness, which I would recommend if people haven't looked at it, is the authors actually draw the analogy with a fox guarding the hen house, essentially. This is the position that drug companies can be in with guidelines, because when you define who has a condition, you potentially are defining a market depending on what you're selling. And I think this shows sort of almost the opposite kind of pattern, but this is the recent hypertension guidelines, and the number of people who are defined as having hypertension and having blood pressure under control, and how this changed with the more recent hypertension guidelines, which are, accept higher blood pressure targets, are somewhat, going to lead to lower estimates of prevalence. And there are a couple points I wanted to make here. And what this does is it talks about the prevalence in middle-aged adults and older adults. And this is the old guidelines are in dark blue, and the newer 2014 guidelines in light blue. And what you can see is that often, or at least in the case of hypertension, and this is true for many conditions, is the biggest changes are in older adults. So, suddenly fewer patients are eligible for treatment, and an awful lot more patients are actually at goal. The point being here, not the specifics of this particular change, but the point being that often when you change the threshold for defining a condition, you can overnight, define large swathes of the population as having or not having a condition. And because many health conditions become more common as we grow older, this often has the greatest impact at older ages. Now, I think probably the most substantive criticism, if you like, of a guideline-based, evidence-based approach for caring for patients has actually come from the geriatrics community. And Mary Tinetti and Cynthia Boyd have, done some very nice work in this area, making the point that, patients, especially older patients, and many of the examples I will draw from will be in older adults, have not just one condition, but two or more conditions. And Cynthia Boyd did a very clever paper in the mid-2000s in JAMA, where she took a hypothetical woman, 79-year-old woman with hypertension, diabetes, osteoporosis, osteoarthritis, and COPD. And I always like to point out that this person probably had chronic kidney disease as well. But for us at the VA, this is a fairly benign set of conditions here, and limited in length. But the point is, what they went through and they said, what would this person's day look like if they did everything that they were told to do in the guidelines, the various different guidelines for each of the conditions that they have. And, you can sort of see the day, starting at 7 a.m. with the metered dose inhaler, the alendronate, the sitting upright for 30 minutes after you take the alendronate, the checking the feet, the checking the blood sugar, etc. And so the day goes on. And what she found when she did this was that there were a lot of conflicting recommendations. So what would be good for one condition might not be good for another. There were treatment interactions, so medications that were beneficial for one condition but harmful because the patient had another condition, etc. And of course, the big picture is that this person's day is really medicalized and really focused around their medical treatment. So, I think that this is, if you like, what we've come to see as a more patient-centered perspective. Fine to have all these population-based guidelines and recommendations, but ultimately you're talking about people here, and how does this impact them? So for the rest of the talk, I wanted to use a framework that has been recently developed by the American Geriatric Society working group or panel on the expert panel on the care of patients with multimorbidity. And Mary Tinetti and Cynthia Boyd and a lot of the people who did this work, were part of this effort. And this is I don't like to spend my time usually reading guidelines, but I would actually say that this document is a pleasure to read. It's really not a guideline. They actually call it guiding principles. And it's very scholarly and thoughtful, and I would recommend it to anyone interested in this area. And they use a framework, and interestingly, the framework starts with patient preferences. Note, it doesn't start with the evidence. And again, it's a subtle shift, but I think it's a very big shift, and I think it's an important shift. What are the patient's preferences? What are their goals? What is most important to them? This becomes important in ordering all those different recommendations, which ones to focus on. What's their prognosis? How much time do they have left? And then evidence is important still. I'm not suggesting it isn't, but interpreting the evidence in light of the individual patient that you're caring for. Things like clinical feasibility. I mean, many of the clinicians in the audience will recognize that, the best laid plans sometimes don't work out. And so considering that explicitly, what can be done in this situation with this patient? And then just kind of looking at things as part of a care plan, optimizing within a care plan. So not just looking at treatment for diabetes in isolation from other conditions. I'm going to focus for the rest of the talk on the interpreting the evidence piece, and we'll bring this in with examples from kidney disease. And the relevant sections that we're going to cover in terms of interpreting the evidence are going to be an assessment of the applicability and the quality of evidence. These are recommendations for steps that a clinician should go through. We're going to talk about the kinds of risk measures that are used, and I hope to illustrate that the difference between a sort of a more evidence versus patient-centered approach here. And we're going to talk specifically about relative and absolute risk. We're going to talk about time horizon to benefit, and I'll explain all this as we get to it. We're going to talk a lot about harms and burdens of treatment, and then outcomes. So that's just to give you sort of a framework for where we're heading. I have given this talk before to a nephrology audience, but this is the first general audience. I want to take a few moments to just tell you, we have some fairly recent guidelines in our field. There's been an ongoing refinement and iteration of guidelines for at least the last 15 plus years in our field. And this is a recent guideline from 2013, which is an evolved version of earlier guidelines. Kidney disease, improving global outcomes is the nonprofit that develops most of the guidelines in our field, or KDIGO. I don't know how many of you will have seen this. People in nephrology are very familiar, but there's been an effort in our field to use a risk-based approach to managing patients with kidney disease based on level of albuminuria or proteinuria and level of EGFR. And so this is the level of EGFR, this is the level of albuminuria, and so you sort of come up with this, if you like, two-dimensional, what's often referred to as a heat map level of risk, with these people with higher levels of GFR, lower levels of albuminuria being at low risk for various different outcomes, and I'll talk about those. And then these people with high levels of proteinuria and low levels of GFR being at high risk, the red areas. And so this is sort of the, state of the art. And, I would just emphasize that this is an example of a population-based approach to management, that it very much comes out of the evidence-based tradition. This is just a sort of background, but I just want to make the point. This is looking at the prevalence of a low EGFR, and as you can see, it increases markedly with age. These are the 70 and older. This is stages 1 and 2, which is just proteinuria. It doesn't go up. It goes up a bit with age, but not a lot. This is stage 3, so this is people with GFRs in the 30 to 59 range. And this stage has been broken down in more recent guidelines. But you can see there's sort of an almost exponential increase in prevalence with age. This is very much driving the overall prevalence of kidney diseases, this relatively moderate decrement in GFR. And then this is more advanced stages of kidney disease, the patients we tend to see in clinic. There is an increase with age, but it's not nearly as dramatic. So the point being that, to all intents and purposes, this is often a disease of aging as currently defined. Now, this is a busy slide that I'm actually going to come back to in a later slide. So just to summarize, this is relative risk of death. This is relative risk of ESRD. This is absolute risk of death. This is absolute risk of ESRD. by age group, with blue being sort of the youngest age group and the red being 75 and older. And this comes from a JAMA paper that actually described all of these risks across age groups, big contribution. And really, the party line here, from an evidence-based approach is that, no matter what your age, if your GFR is going down, you're at higher risk for death and you're at higher risk for ESRD. And so, I just want to, I will circle back to this, but to say some more about it. But the point being that we currently have a treatment strategy for patients with kidney disease that is population-based. It's evidence-based, if you like, based on information from populations, and it's pretty uniform. It's sort of age-neutral, and I think it's an example of evidence-based approach. So I want to go through now and deconstruct this approach a little bit using a lot of examples related to older patients with kidney disease, because I think this is where some of the fault lines appear in the evidence-based approach, certainly to kidney disease. So first of all, just talking about the applicability of the evidence. So we have actually a very nice review that appeared in the Annals some years ago, summarizing the current state-of-the-art knowledge of what is helpful, what is not in patients with kidney disease. And essentially, the evidence that we have for what we do is fairly limited, actually. We have evidence for the role of ACE inhibitors versus placebo for slowing progression of kidney disease in patients with proteinuria and mostly in patients with diabetes. We also have evidence for ARBs versus placebo for lowering risk of ESRD. Since this was published, there's also some evidence for the low-dose statins for lowering risk of major atherosclerotic events in patients with kidney disease. But this is actually pretty much it in terms of the available evidence in our field, and it's strong evidence, but limited. And they did a very thorough review. So we did a study, and unfortunately we did it before this study, or I would have been nice to use their excellent review to do this study, but we did our own review of the trials that provide a foundation for current guidelines, or actually it was the last set of guidelines at the time when we did this study. So we looked through all the guidelines, we looked at the trials that they cited, and then we looked through all those trials, and this is trials of ACE inhibitor or ARB to slow progression of kidney disease. And the first point is that most of these trials did not enroll older adults. 76% actually excluded older adults, either implicitly or explicitly. At the time when we did the study, no one had done a subgroup in older adults in these trials. So someone did one after the fact, but it was a relatively young subgroup. About 70% only enrolled patients with diabetes. And of those trials, most required that patients have proteinuria. And the reason for this is that part of the mechanism for how ACE inhibitors work is by lowering proteinuria. So it makes sense, but just making the point that most of the patients in the trials had proteinuria. In non-diabetics, some of these trials were in non-diabetics. They usually didn't explicitly require proteinuria, but when you look at the participants who were in the trial, most did have proteinuria. The trial that is really, in some ways, the exception in many ways is the ALL-HAT trial, which was actually not a renal trial, as you all probably know, which actually did not show a benefit to ACE inhibitors in terms of slowing progression. And because it wasn't a renal trial, didn't ascertain proteinuria, shock horror. But to many nephrologists, didn't ascertain proteinuria, therefore couldn't require that people had proteinuria to be in the trial. So we don't really know how many people had proteinuria in the trial. And so this is often, the results of this trial, which, by the way, did enroll older patients and had the highest mean age of patients, so it was an older, high-risk population, didn't show a benefit. This is often dismissed in our community because, well, they probably didn't have proteinuria. But, which makes sense, from an efficacy point of view, you want to do a trial in a population who's likely to, at high risk for the outcome. You want a best case scenario, right, for sort of face validity. It would almost be unethical to do a trial in a population who you didn't think would necessarily benefit. But when you look at the composition of the older population with kidney disease, one thing because of how kidney disease is defined, below a certain EGFR, it just so happens that this is sort of proteinuria. This is a composition. So this is people with proteinuria. This is people with proteinuria and a low GFR. This is people with a low GFR but no proteinuria. And as you can see with age, this group really is the dominant group. So when you think about generalizing the results of trials to older adults with kidney disease, actually most of them don't have proteinuria. So maybe the results of ALLHAT are actually most relevant to this population. It certainly raises that question. We then looked in the same paper, we looked in NHANES, which is a nationally representative sample of U.S. Adults that measures creatinine and albuminuria, among a lot of other things. And we looked by age group, so this is youngest age group, older than 70. And we looked at the percentage with proteinuria. And so in the younger age group, it's about 40%. It's only about 12% in this older age group. And if you look at people without diabetes, it's actually even lower. And most people who meet the criteria for kidney disease don't have diabetes. So we sort of have a situation where we have trials that are conducted in younger adults predominantly with proteinuria, with diabetes. Then we have a population of older adults with kidney disease, which is the largest group with kidney disease, who don't have proteinuria, and many don't have diabetes. So there's a mismatch. So I think it's unknown. Many of our current guidelines recommend the use of ACE inhibitors in patients with kidney disease. Actually, the nephrology guidelines are more conservative than the hypertension guidelines. Nephrology guidelines, suggest only with proteinuria, but that's been interpreted much more broadly. So these medications are widely recommended in anyone with kidney disease. So, okay. Second point I wanted to go on was to talk about the measures that we use. And I'm going to talk a little bit about relative and absolute risk. So David Sackett did a nice sort of just illustration of how relative risk reduction works. So what he did, so he has a population here, and he's looking at risk of stroke. And so we have two populations, both with an intervention that reduces the relative risk of stroke. 0.4 is the relative risk. And then these populations have very different absolute risk of stroke, baseline risk. The top one has a high baseline risk, the bottom one has a low risk. And then this is the absolute risk reduction that you would get if you applied that relative risk reduction. And then this is, if you take the reciprocal of that absolute risk reduction, you get something called the number needed to treat, which is the number you'd need to treat to prevent one case in the population, one case of stroke in this instance. And you see that the number needed to treat is much higher for the lower risk population. Again, this is sort of intuitive, but I just wanted to make sure I illustrate this, because what I want to talk about is then we sort of applied this in another study in patients with kidney disease. So similar kind of structure to the other study, different study. We looked at the relative and absolute risk reductions for major trials of ACE inhibitors and ARBs that showed a reduction in the risk of end-stage renal disease. And end-stage renal disease, although sometimes it feels common to us as nephrologists, is a relatively rare outcome on a population level. And so what they did was they enrolled patients in these trials who were likely to develop ESRD because they didn't want the trial to go on forever. What they found were relative risk reductions between 23 and 56%. They got absolute risk reductions varied depending on the baseline risk in the population, but when you create the reciprocal of those, the number needed to treat range from 9 to 25 in these trials. And bear in mind that, most people don't even read the abstract. Most people, maybe they read the, media release or whatever. So the number needed to treat is a number that tends to get messaged around. And you hear a number needed to treat, in this range, you think, well, that's pretty good. And it is for most people. But what we did was we took a veteran population, national population of veterans in whom we knew what their EGFR was and their level of proteinuria. And we used kind of similar categorization by level of GFR on the top and level of proteinuria, dipstick proteinuria here. And we sort of divided people, by their level of GFR and proteinuria. And then we applied skipping ahead here, we applied a 30% reduction in relative risk. This is hypothetical. Let's say everyone had a 30% lower risk of ESRD as a result of taking some hypothetical, let's say, ACE inhibitor or ARB. And then we applied it to the absolute risk of ESRD in each of those groups, which varies dramatically even in people with kidney disease. By the way, these people all had kidney disease. So the number needed to treat, if you were to do this, ranged from 16, which is pretty similar to what they got in the trials, up to 2,500. Which is very, very high, and I think most people probably would not consider that to be a significant benefit. The point here is that these lower risk groups actually account for the majority of people with kidney disease. So, I think it's about 90% of people in this cohort were in a group with a number needed to treat greater than 100. So this is very, very different than the results from the trials. If you were to even, and that just assumes that these people are going to get a similar benefit to the patients in the trials, which is certainly probably not the case. But so important, I think, when interpreting evidence to really think about it in terms of the characteristics of your patient population. Another, way that information is presented in trials, and what I'm trying to sort of do here is build the case that often the way information is presented to us and the kind of studies that are done are often not providing us with information that really supports patient care. It's not necessarily the kind of information that's most useful to patients. So the second point here is often over the course of a trial, you'll hear about the overall benefit over the course of a trial. And the duration of a trial is often somewhat arbitrary. It's based usually on, estimated costs, feasibility, etc. It might, and the time needed to reasonably detect a treatment effect. It might not be a time period that's that meaningful to an individual patient. And so what the American Geriatric Society working group suggested was that studies should spend more time reporting how long does it take to see a benefit in a trial, or the time horizon to benefit. And I show you, again, another renal trial here. This is the SHARP trial that I mentioned earlier that showed a benefit to low-dose simvastatin for major atherosclerotic events. And what you can see here is that there really was no detectable separation in these curves for at least a year. So, if your life expectancy is less than a year, this may seem obvious, but, this treatment, you're not going to live long enough to see a benefit to this treatment. So, again, having information on that, how long does it take to see a benefit, not what's the benefit during the trial, could be more useful to patients. And certainly the 5-year duration of this trial, which I'll show you later, in reference to survival time for older adults with kidney disease, is a long time. Many patients are not going to live this long. And one of the things that comes up a lot in our field is the competing risk of death versus progressing to the point where you start dialysis or need kidney transplant for your kidney disease. Although it's a relatively, as I say, on a population level, rare outcome, the patients that we deal with, it's often a very real consideration. And the question is often, and I'll explain, this graph is a little complicated, but the question is often, am I going to live long enough where I even need to worry about developing end-stage kidney failure? This was a study that we did some years ago where we looked, again using veteran data, national veteran data, we looked at, by level of GFR, this is sort of a summary of our results. Let's say, you take a eGFR of 30. If you're a younger person, this is a younger age group, then, you're probably going to, be more likely to live and develop end-stage renal disease than you are to die before that happens. But as you get older, it becomes more likely that something else is going to happen to you first, that you're going to die before you ever get to that point. So this is just to say that in our field, this notion of competing risk is often very important in the clinical setting. And to illustrate this, I wanted to sort of go back to that study that I just showed you, where the hypothetical study where we looked in a older veteran cohort with kidney disease. And the median survival ranges from about 3 years for people with the lowest levels of GFR and the highest levels of proteinuria, which is sort of the population we're tending to see in clinic. That's the median survival. Up to about 8 years and this is older patients, older than 70, for people with, just moderate reductions in GFR and no proteinuria. So we see a lot of heterogeneity in survival time within our population, and you'll kind of notice that each of these medians has a 25th and 75th percentile around it, and meaning that even if you know the median survival, there's a lot of variation in survival within each of these sort of risk-based categories that we've been handed in our guidelines. So again, we're sort of taught to manage patients based on their risk for various outcomes, but often you can't get a very precise estimate of that within a group. So that's sort of a side point. But so when we give a drug or perform some kind of intervention, and we have a trial that says it's beneficial over 5 years in a high-risk population, often what we do, because we can't always do all the trials we want, is we say, well, if you gave the lower-risk population more time, they would benefit, right? That's sort of what we basically do. Or, and that's an acceptable thing to do. Except if your patients actually aren't going to live a very long time. That actually is not a fair assumption. And so what we did was we then said, okay, we did, I may have forgotten to mention, we ran our hypothetical trial for 3 years. We then extended the time frame to 10 years. We said, okay, let's do a 30% risk over 10 years. And still, the numbers needed to treat were very high. And still, most people were in categories where the number needed to treat would be more than 100. So that's just an illustration of the fact that extending the time frame doesn't always give you the same results as in the trials, because actually about 65% of these patients died within 10 years of their cohort entry date. So I was going to circle back to this graph because I think there's an interesting point to be made. So the party line on this, this study in JAMA, many of the people who participated in this study are also involved with the guidelines for kidney disease. And part of the goals of this study was actually to generate data to support the guidelines. It's interesting. And there's been a lot of controversy in our field about age. So you have an 80-year-old person with a GFR of 55. Is that really kidney disease? Well, if you believe the guidelines, yes, it is kidney disease. But, there's a certain amount of circumspection about that. And so there's a lot of interest in what happens with age. And so the party line here is that, the red line is the older age group. Even if you're elderly, your risk goes up with low GFR. So, one size is for all is probably reasonable. In fact, the absolute mortality for older adults is higher at all stages. So if you were to have an intervention that reduced mortality, you would prevent a larger number of deaths in this. Here, a larger number of deaths in older adults. Therefore, essentially the same categorization, the same paradigm is useful at older and younger ages, and that's the party line. I don't know if you're familiar with this drawing, where you can see an older woman or a younger woman, whichever, depending on which way you look at this picture. And And I think that this is a similar kind of situation, because another way you could interpret this data, and we've interpreted similar results in the VA differently, and you see that in older adults, the relative risk is less than in older adults. And you see that the absolute mortality risk is higher. So, the survival time is actually lower, and this is no surprise in older adults. So, a lower relative risk, a lower survival time means that as your GFR goes down, we're talking about lesser increments in survival time, which is often what matters to patients. Now, I can't tell you what's a high or a low survival time for a particular patient. That's going to depend on the patient and what's under consideration. But, I will say that I think in older adults, loss of GFR, especially at these sort of marginal levels, in the 50, 40, 50 range, may not be that significant in terms of the difference in survival time, big picture compared to younger patients, with a caveat that it depends on each person. So I think that is a more patient-centric way of looking at this. It's a less population-based approach, but often more helpful when you're dealing with individual patients. I want to wrap up fairly quickly here and talk about harms and burdens, which are often the most important thing to the patients. Among the clinicians here, I think that's often what when you talk to patients, that's what they want to know about. This is a study that Terry Freed did, a hypothetical study, where she asked people, if you had a medicine that could lower your risk of heart attack from 20% to 14%, would you take it? And she's looking at the people who said yes, which is actually most people own the benefit, right? So then she said, of these people, she said, okay, so if you got daily fatigue and dizziness, but your function was okay, would you still take it? And, about half said they would still take it, but the other half didn't want to. How about mild to moderate nausea, no effect on function? Only about 35% wanted to take the medicine. How about daily fuzzy or slowed thinking? Only about 30% wanted to take the medicine. Then to all of these, she added adverse effect on function in addition to those. In other words, you can do less. Only about 11, 12% in any of the groups would take the medicine. So I think this makes the point that harms are very important to patients. And the point I want to make here is that very often in clinical trials, we have very careful ascertainment of primary outcomes, efficacy outcomes, not such careful ascertainment usually of side effects, even if they're ascertained, but they're not usually analyzed with the same degree of rigor as benefits. So, the last point I'm going to make is the selection of outcomes. So in our field, end-stage renal disease is considered, one of the most important outcomes, but it's defined as starting dialysis or receiving a kidney transplant, which is actually a treatment decision. So it's complicated. Also, people look at change in GFR, but again, when you give an ACE inhibitor, you often see lowering or rising creatinine, lowering GFR. What does that mean long term? But I think the bigger point, and we in our field need to probably get away from these disease-specific outcomes, as many fields do, because what often matters to patients, in addition to these sort of disease-based outcomes, are things like, am I going to be able to live on my own? Am I going to be able to function? How am I going to feel? This kind of thing. And the geriatrics working group have been working on developing what they call some universal outcomes, such as, general health, pain, function, etc., that are cross-cutting, that are not tied to particular disease processes. So again, I think there's work to be done here in building trials to test outcomes that often matter to patients. And, in doing this, we may need to get away from our own disease-specific measures. The last point is just the use of composite outcomes. Often in trials, we'll do that because, or I shouldn't say we, since I've never done a trial, but people will do that because you lump two outcomes together. It means you don't have to have your trial running as long. You might be able to detect an effect sooner, etc. But that doesn't always make sense to the patient. So if I use these two competing outcomes of death and end-stage renal disease, does it really help to know that the risk of death or end-stage renal disease is X? Not really, because the clinical question is often, well, wait a minute, what's my life expectancy, but also, am I likely to need dialysis before my life is, before my time is up, that kind of thing. So again, just saying that sometimes the way that things are presented are not exactly the way that would be most useful. So I hope I made the point that, anything from, the choice of the study you do, how you design it, who your target population is, what outcomes you choose, what interventions you choose or exposures, what, how you report the results, etc., is important and can be framed differently for different agendas, and will not always be the same for the patient as it will for other groups, particularly I'm thinking sponsors of trial, drug company sponsors, or even our own academic interests may not be those that are most meaningful to patients. So I think it's important to think about that explicitly. There are ongoing initiatives. Most of you will be aware of PCORI. NICE is the guideline-making organization in the UK, are really seriously engaging patients in the research enterprise, which I think is very encouraging. I think there's a growing interest in having more flexibility about different methodologic approaches, pragmatic trials, alternatives to the standard randomized controlled clinical trial. I think there's efforts to bring sort of shared decision-making into existing guidelines. There's been some hints of that in recent blood pressure and cholesterol guidelines. I think the working group on universal health outcomes is going to be very important. And then I think we see, care models also that are more slanted toward what's helpful for the patient. Steve's done a lot of fantastic work in the VA to build the patient-centered medical home model. And so anyway, with that, I particularly want to thank Eric Larson, who's been a fantastic mentor to me, but also my colleagues and mentors and leaders here at the university. It's been a wonderful environment. So.
Anne?
Yeah.
Yeah, hi. Wonderful talk. Thanks. So clearly this is a fantastic way and clinically relevant way of dealing with patients. For those that are not in the VA, and perhaps in the VA too, we have this other big issue coming down, which is already here, and that is if we don't follow certain benchmarks and reach certain outcomes, we're not going to get paid for it. And so I wonder how you and others from the academic side are trying to integrate and think of this as we move forward into this new era of payment.
Mm-hmm. Well, I think if you believe in this framework, which not everyone does, I'm sort of just presenting one framework, I think you're right. There's changes that need to occur at multiple levels. And, how do we measure the quality of patient-centered care, et cetera? And I think we are caught, if there is going to be a shift this way, I think we are caught in a difficult situation where we do have, on an individual patient level, there's conflicting agendas here, and it puts the clinician in a terrible situation. I don't know what advice to give you, except that I think things need to change at multiple levels. And I don't, Steve, if you have any thoughts, as you think about this a lot. Or...
I'm going to try to talk about that. It's a thorny problem.
Yeah.
Thank you for a wonderful talk. One thing you didn't address that's often a burden for patients is cost. And in my field, hematology oncology, the cost of chemotherapy agents also has to figure into decision-making with the patient and the families. When I think of NICE, I think of a group that does consider cost. And here, PCORI, I think, does not. Do you think we'll ever get to a place where we incorporate cost into these guidelines?
Well, that's a really great question. I'm not sure I'm well qualified to answer it, except that I'm from the UK originally. And it's a very different culture. And I think, they're coming at this from a very different direction than we are in the US, in the sense that I grew up in, England. Many choices that you have in this country were simply not choices. So I think, what they're doing there is they're being explicit about that. And that's maybe easier to do in that culture of where there isn't the expectation of having every choice. No, I think it's an enormous issue. I don't think I would be foolish enough to wager whether it will ever come in, but I think for sure it's a reality, especially I think for end-of-life type care where is the time where costs really escalate. I feel privileged in the VA, at least as a ground truth. I feel like it isn't something I have to think about with my patients. Sometimes I have to battle for non-formulary drugs, and that's one of the reasons I personally choose to practice in the VA, because I can really, I think, care for patients in the way that I feel like I want to care for them.
Great, thank you very much.